Welcome to Roadmap to Residency. Today we are diving into glomerular diseases for the United States Medical Licensing Examination Step 2. This video focuses on high-yield question stems and test-taking strategies, not comprehensive teaching. We will walk through real board-style questions together. Make sure you have first aid and UWorld ready to reference as we go. Let us get started. Here are your learning objectives for today. By the end of this video, you will be able to rapidly distinguish nephrotic from nephritic syndrome, which is one of the most commonly tested distinctions. You will recognize buzzword patterns that point to specific diagnoses. You will know exactly when biopsy is needed versus when you can diagnose clinically, and you will understand which immunosuppressive therapies match which conditions. These skills will help you answer questions faster and more accurately on test day. This is your foundation for every glomerular question. Before looking at answer choices, ask yourself, is this nephrotic or nephritic? Nephrotic means massive protein loss, greater than 3.5 grams daily. Think edema, low albumin, and high lipids. The key urinalysis finding is protein without blood. Nephritic means inflammation. You will see red blood cell casts, which are pathognomonic for glomerular inflammation. Expect hypertension, some protein, and rising creatinine. Many questions hinge on this single distinction, so master it now. Let us lock in these buzzword associations because the boards love testing them. Minimal change disease, child with sudden swelling after a viral illness, protein in urine but no blood. Immunoglobulin, a nephropathy, young adult with bloody urine appearing within 1 to 2 days of getting sick. Post-streptococcal glomerulonephritis, child with cola-colored urine and swelling 1 to 3 weeks after strep throat or skin infection. Notice the timing differences. These details matter and will be in your question stems. Here is our first practice question. Read through the stem carefully. A 4-year-old boy, facial and leg swelling, recent cold, heavy proteinuria with no blood, very low albumin. Before looking at answer choices, what syndrome is this? What is the most likely cause in this age group? What should you do next? Take a moment to think through your answer. Let us break this down systematically. Step 1. This is classic nephrotic syndrome in a child. Heavy protein, low albumin, edema, no blood in the urine. In children, over 90% of nephrotic syndrome is minimal change disease. Step 2. Here is the key test-taking strategy. In a child with typical first-time nephrotic syndrome, you do not need a biopsy. The clinical picture is enough. If you see biopsy as an answer choice in this scenario, eliminate it. Step 3. The correct answer is empiric corticosteroids. Minimal change disease responds dramatically to steroids. Review this concept in your board resources. It comes up repeatedly. Now for case 2. Different presentation here. An 8-year-old girl with dark urine and facial swelling. Sore throat 2 weeks ago. Blood pressure is elevated. Red blood cell casts on urinalysis, low complement, and positive strep antibodies. Again, pause and think. Is this nephrotic or nephritic? What is the diagnosis? What confirms it? This is a classic nephritic picture. The red blood cell casts tell you there is glomerular inflammation. Here is your critical test-taking strategy for timing. Post-streptococcal glomerulonephritis has a latent period of 1 to 3 weeks between infection and kidney symptoms. Immunoglobulin. A nephropathy presents much faster, within 1 to 2 days. This patient had symptoms 2 weeks after pharyngitis, pointing to post-strep. The low complement and positive strep antibodies confirm it. Most children recover with supportive care only. Make sure you review complement patterns in glomerular diseases. Now let us cover 2 high-yield topics for the boards: when to biopsy and which immunosuppressive to choose. For biopsy indications, remember these scenarios. Any adult with new nephrotic syndrome, children who do not respond to steroids, rapidly progressive disease with rising creatinine, unclear nephritic syndrome, and lupus nephritis to determine the class. For treatment, know that minimal change disease gets steroids first. Focal segmental gets steroids but responds less well. Membranous now favors Rituximab. Lupus nephritis uses mycophenolate or cyclophosphamide for induction. Immunoglobulin. A nephropathy relies on angiotensin blockade. Case 3 is a common board scenario. Middle-aged diabetic, 15 years of disease, now has retinopathy and significant proteinuria. His kidney function is starting to decline. What treatment slows progression? Think about what class of medication protects the kidneys in diabetes. The pattern recognition here is straightforward. Long-standing diabetes plus retinopathy strongly suggest diabetic nephropathy. Here is an important pearl. If a diabetic has kidney disease but no retinopathy, consider other causes and possibly biopsy. The test-taking strategy for treatment is clear. Angiotensin-converting enzyme inhibitors, or angiotensin receptor blockers, are first-line regardless of blood pressure. They reduce pressure in the glomerulus and slow proteinuria. Never combine both drug classes together because of hyperkalemia risk. Sodium-glucose cotransporter 2 inhibitors also provide kidney protection and are increasingly tested. Case 4 is a renal emergency. Older woman with creatinine that quadrupled in 1 month, red blood cell casts, lung infiltrates, and positive cytoplasmic pattern anti-neutrophil cytoplasmic antibodies. She also has sinus and nose symptoms. What should you do immediately? This is rapidly progressive glomerulonephritis, a true emergency. Without treatment, she will reach end-stage kidney disease within weeks. The antibody pattern and multi-organ involvement point to granulomatosis with polyangiitis, which is a type 3 porcine-immune crescentic glomerulonephritis. For classification, remember, type 1 is anti-glomerular basement membrane, or good pasture. Type 2 is immune complex, like lupus. Type 3 is porcine-immune with anti-neutrophil cytoplasmic antibodies. The correct answer is urgent biopsy followed by aggressive immunosuppression with steroids and cyclophosphamide or Rituximab. Add plasmapheresis for severe disease. Never choose watchful waiting in rapidly progressive glomerulonephritis. Our final case is an adult with 1 month of leg swelling and foamy urine. No prior medical history except testing positive for hepatitis B. Heavy proteinuria, low albumin, but importantly, no blood in the urine. What is the most likely diagnosis in this adult with nephrotic syndrome? This is membranous nephropathy, the most common cause of primary nephrotic syndrome in white adults. Unlike pediatric nephrotic syndrome, adults need biopsy for diagnosis. The key test-taking strategy here is recognizing secondary causes: hepatitis B and C, malignancy, especially in older patients, lupus, and certain drugs can all cause secondary membranous nephropathy. This patient has hepatitis B, so treating the infection is the priority. Thank you so much for watching this high-yield review of glomerular diseases. If you found this helpful, please like and subscribe to our channel. For personalized tutoring and residency advising, visit roadmaptoresidency.com. Our expert tutors can help you reach your score goals. Good luck on your exam, and we will see you in the next video.